How do we navigate psychedelic medicines and cancer when the research shows clear promise but not definitive proof of how to best use these medicines? And how do we build the infrastructure for providing safe, legal, and affordable psychedelic therapy for people living with cancer? In today's podcast, we're speaking with Dr. Linda Carlson. Linda is a professor of psychosocial oncology at the University of Calgary and a principal investigator for the Canadian Network for Psychedelic-Assisted Cancer Therapy, also known as CAN-PACT. CAN-PACT is a 5-year, $5 million initiative building nationwide infrastructure for psychedelic therapy in Canada. She's recently spent the last 25 years establishing integrative oncology interventions in cancer care. She recently completed a systematic review of psychedelic research in cancer, and she's the past president for the Society of Integrative Oncology. In this episode, Linda and I explore what the current research really shows about the use of psychedelics in cancer. There are promising signals from small studies, but also significant gaps remain about dosing and patient selection and therapy protocols. And we discuss why healthcare providers generally feel positive about psychedelics, but also have concerns around safety and training and access. We also discuss demoralization syndrome as a more accurate term than depression or anxiety for capturing the psychosocial realities of living with cancer. And we examine CAN-PACT's comprehensive approach to building infrastructure for psychedelic-assisted cancer therapy, building networks with patients as full partners, using structured consensus to identify top research priorities, and training therapists in cancer centers to ensure equitable access. This podcast is brought to you by Healing Cancer Journeys. Our mission is to provide education and community for people exploring psychedelic medicines in their cancer journeys. You can find us online at www.healingcancerjourneys.org or follow us on Instagram, TikTok, YouTube, and Substack, where our handle is Healing Cancer Journeys. As a reminder, this podcast is for educational purposes only and is not intended as medical or legal advice. Thanks for listening, and I hope you enjoyed today's podcast with Linda Carlson. Linda Carlson, welcome.
Thank you. I'm really happy to be here today.
We're very excited to have you. So, Linda, a lot of what we're going to be talking about today falls into the category of integrative oncology. And I think integrative oncology goes by many names, but would love to hear your perspective on how you define it and how you think about integrative oncology.
Sure. I mean, at highest level, integrative oncology is just combining the best of what we would call complementary therapies with the best of conventional, quote unquote, therapies, right? So to understand what we mean there, you have to take a step back and look at the definitions of complementary therapies versus alternative therapies. And then there's the sort of umbrella of psychosocial oncology, which is really my home profession, but let's stick with integrative oncology. Complementary therapies, there's a few main categories. So the area that I've really focused in is mind-body therapies. So that's stuff like meditation, yoga, tai chi, hypnosis, relaxation, all these kinds of therapies that affect, well, they all do, but affect the mind and body really obviously. So those are the mind-body therapies. Within integrative oncology, there's also natural health products like herbs and vitamins and, nutrition, certain diets. Exercise is a big area. And then it also includes things like traditional medical systems, like traditional Chinese medicine or Ayurvedic medicine and all the different bits and pieces there, as well as energy therapies like, say, Reiki or biofield therapies, healing touch. So a wide range of things. The key with integrative oncology is that all the treatments that we recommend or that we're looking at are evidence-based, or we're studying them to understand the evidence. So within integrative oncology programs, we're always turning to the evidence in conjunction with clinical experience, and that's how we decide what to recommend or what to use in our programs.
Mm-hmm.
So I guess it's important to make the distinction between complementary therapies, which are used alongside conventional care, and alternative therapies. And so alternative therapies, they could be the same things, but they don't have very much evidence to support them or any at all. Often they are touted as a cure for cancer or instead of conventional care rather than alongside. Often people have to pay out of pocket. They might not be readily available, or there's a really high cost, or you have to go to some other country to gain access to these. And so with the lack of evidence for some of the alternative treatments, it doesn't mean they don't have potential, but to move them into the integrative space, we need to study them and better understand them and see if they do have benefit and in what way. So it's important to, I guess, take into account those sort of distinctions when we're talking about the broad field of integrative oncology.
Okay. So integrative oncology, evidence-based and complementary to conventional therapy. And
Absolutely.
you mentioned that your field of study is really in the mind-body area. You've done a lot of research, particularly on mindfulness-based stress reduction. You wrote a book, Mindfulness-Based Cancer Recovery. Tell us a little bit about MBSR, mindfulness-based stress
Sure.
reduction, and some of the benefits for people living with cancer.
Yeah, so MBSR is kind of a generic, I guess we would call it, program that was developed by a guy named John Kabat-Zinn back in the late 1970s, so 1979. He originally sort of started MBSR. Weaving my journey into it, like I first heard of John Kabat-Zinn and met him actually when I was in graduate school. It would have been 1995, and he came to Montreal. I was at McGill as a student, and was starting to meditate and have an interest in that area. And he came and he introduced a group of us to MBSR. They'd never heard of it before that. So that was around 1995. And I was in grad school from 92 to 98. And I was studying the mind body connection, the scientific study that's called psychoneuroimmunology or psychoneuroendocrinology. So, actually, scientific understanding of how the mind, the brain, our thoughts, our feelings, our cognitions, our emotions, affect what's happening in all these different systems in the body. So the nervous system, the endocrine system, now there's a lot of interest in the gut brain axis, that kind of stuff. So I was studying that, not within the context of cancer or meditation, really just trying to understand actually hormones and behavior, but was doing a parallel journey with my own practice of meditation and my own practice of yoga. And so that all came together. And when I finished, my PhD was 1998. And I came back to Calgary, which is where I'm originally from, and started working in a cancer center. And so I knew about MBSR, and I guess I should describe that a bit more. So MBSR is a standardized 8-week group-based model where people get intensive training in mindfulness meditation. And alongside the training in mindfulness meditation, they learn a lot of theoretical background and skills like around the mind body connection, around the stress response, around
Mm.
stress reduction. So, really, what John Kabat Zinn did was combine the best of these sort of ancient Eastern meditation techniques, largely from Buddhism, different schools of Buddhism, with Western concepts around stress reduction. And he created the MBSR program. Again, it's 8 weeks, it's group based. There's home practice every day, different types of meditations that people learn and different ways of coping. And so that generic MBSR has been adapted over the last 40 years or so to many different applications. So there's mindfulness-based cognitive therapy, which is specifically or was developed for people with depression to prevent relapse. And we developed one called mindfulness-based cancer recovery. And so it's taking the MBSR principles and adding in approaches or a recognition or treatment of the types of psychosocial experiences and problems and concerns and side effects that are specific for people with cancer. And so that's how MBCR is a little different than MBSR. But as an umbrella, we call them all mindfulness-based interventions or
Mhm.
MBIs. Right. So within the MBI framework, it's all of those things: MBSR, mindfulness based cognitive therapy, other adaptations that are out there, but follow the same kind of model.
Yeah, yeah. All right, good. And you've published some interesting research, and I want to read the name of the paper because I think it's pretty descriptive. So this was published 2015 in the journal Cancer. So the article is Mindfulness-Based Cancer Recovery and Supportive Expressive Therapy Maintain Telomere Length Relative to Controls in Distressed Breast Cancer Survivors. It's a mouthful of a title, but again, I think
Stories in the title, right?
it's completely descriptive. And I really want to focus in on telomeres there and tell us a little bit about, in layman's terms, what is a telomere and why were you studying telomere length when it comes to some of these mindfulness practices?
Sure. Can I just back up a bit and tell you a bit
Absolutely.
into that? Yeah.
Yeah.
So when we started studying this mindfulness-based cancer recovery, we started with patient-reported outcomes like symptoms, right? Stress, mood, things that are really important day to day for people for coping, fatigue, sleep. But because I have this background in psychoneuroimmunology, we're like, well, let's see what's happening in the body alongside these changes in people's experience. So we would take saliva samples to measure cortisol, which is a stress hormone in the body. We had people monitoring their blood pressure week by week throughout the program. And then we took blood samples where we could look at immune function. So looking at cytokines, which are components of the immune system that regulate inflammation. And so we added in telomere length, in that paper, because no one had ever looked at this. And telomeres are the little caps at the ends of the chromosomes in the DNA that shorten with aging. They're linked to cell aging. And so research had been beginning to accumulate showing that people who experience chronic stress had shorter telomeres than their peers. And we also saw that shorter telomere length was associated with greater risk for earlier mortality and cancer, risk for certain diseases like heart disease, diabetes. So it seemed interesting to see if these mind-body therapies could also impact that at the cellular level. So nobody had done that before, and I went to the cell biologist, a cancer biologist, and I said, what do you think about telomeres? Like, it's only an 8-week program, or a 12-week program. Do you think we could actually move the needle on that? Like, would that be possible in such a short period of time? And she said, well, the turnover is really quick. Like, why not? Maybe, let's look at it. So we said, okay, we've got the blood samples we'd already saved from this study. And the study was 2 different interventions. So the mindfulness-based cancer recovery, but also a support group, a supportive expressive therapy, where people shared their deepest fears and thoughts and concerns about living with breast cancer. And so we compared them to a waiting list group who didn't have any intervention. And so we were able to look at the telomere length before they started the programs, and then afterwards, a chunk of them had done mindfulness or supportive expressive therapy. The rest had done nothing else. They were still waiting. And so what we found was that there wasn't any difference between the 2 active interventions. But when we put them together, just like the title says, and compared them to the controls, they just maintained the same length they started with, but the controls were getting shorter. And that's to be expected because telomere lengths shorten with aging, with cell aging and successive cell division. So that was the first study that had ever shown that this was even possible in such a short period of time related to a mind-body therapy like that. And of course, we don't know what it means long term. Like, we don't even know if it would last long term. We don't know if it would be related to disease progression or outcome. But it was just showing that, as I've always kind of known, that, everything that happens in the mind happens in the body.
And that was what was curious to me is you measured an objective biomarker rather than subjectively reported
Well,
outcomes.
both. Both.
When it was interesting too, it sounds like the telomere was almost like an afterthought in terms of an outcome, and that ended up being the most interesting story.
Well, it was the thing that the media picked up on the
Yeah.
most.
Yeah.
To me, it's not the most interesting story. To me, the most
Interesting.
interesting story is that people felt better. People could live their lives better. People could sleep better. They had less pain, right? They were less anxious and worried. I mean, that's, to me, what really matters, right? But for many people, it's not real unless you can measure it with an objective measurement, like something that's happening in the cells in the body. It was interesting to me, but what's more important is what people tell me.
Well, that's fascinating that you're weighting those self-reported, those subjective outcomes higher than the objective biomarkers. But you measured both. And I think you're right, is that the press, the media pick up on the objective parameters.
Oh, yeah, and there was a big media storm around that telomere thing, like so many, inaccurate headlines actually, but yeah.
Well, good. And so you've got this background in mindfulness-based practices, and you found your way to psychedelic medicines. Tell me a little bit about the connective tissue of how you evolved from that background in mindfulness-based therapies into psychedelic medicines.
Yeah, well, we started so I really started thinking about this area, like our first grant submission was in 2022. So I started thinking about it, around 2020, 2021 kind of thing, when I was starting to see more reports about these benefits for people with cancer from the psychedelics, like largely psilocybin, high dose psilocybin. And they described the mystical experiences and the impact these would have on people. And I'm like, that's a lot like mindfulness. I just saw so many parallels there with what we see in the people who go through our program. There's this sense of meaning and purpose, feeling connected to something larger than yourself, accepting the inevitability of death and not being so anxious about not being able to control things. These central themes, right, are the same. And it was interesting to me to think, okay, well, what if we combine these things? Like, could we really, like, either kind of shortcut the path up the mountain. And I say this all the time, many paths up the mountain. Like, I think it's the same mountain. I really do. Everyone's going to the same place. And there's just so many different ways to get to that place. And so our thought was like, well, if we add on a high dose psilocybin experience, perhaps to the mindfulness that we're already training people in, maybe that would really accelerate and be synergistic around improving some of these outcomes. So that was kind of the idea to begin with. And then a group of us, I'm part of the Canadian Cancer Trials Group, our supportive care committee. And this is a network across Canada. Like CCTG mostly does drug trials, but they have hundreds of sites all across Canada. Like every cancer center is set up to enroll people in their trials. And they've shown an interest in more psychosocial outcomes and more psychosocial studies. And so talking to that group, we were like, this could be a really good application for our group to do a multi-site trial and really move this forward. And so we started writing grants, and, nothing was funded in 2022. Nothing was funded in 2023. I was getting little dribs and drabs here and there. And then in 2024, so I guess last spring and summer, I just said, we really gotta, I'm had enough of this, writing these grants. So I wrote 4 grants. Yeah, I'd written it already like 4 times. I wrote it 4 more times to different agencies. Like, we tried all over the place, and really got lucky with the Canadian Cancer Society grant, what's become CAN-PACT, because it's so much bigger than just a clinical trial now.
Yeah. And I want to talk a little bit more about CAN-PACT later on in the conversation. And it's interesting that you said that the connective thread between some of the mindfulness-based practices that you're researching and psychedelics was that mystical experience. And there's conversations in the community about whether you need the journey, whether you need the mystical experience. And as you know, there are studies on compounds that don't have the psychedelic experience. And I'm just curious. Well, and I'm curious if just your perspective on that. I'm glad they're doing the research, but what is your perspective on the importance or value of that mystical experience?
Yeah, I mean, empirically, we haven't answered that question with clinical trials. I think clinically, you certainly hear from people when you hear their stories that it was that mystical experience that was the breakthrough for them. And there is data. I was just, as I told you, down in Chapel Hill at the Contemplative Research Conference, and some data presented there where they broke down people who, by the level of their mystical experience, because not everyone has the same level. And there's a questionnaire that asks people, how much did you have this self-transcendence and all these mystical type of sensations. And the more people reported having a mystical experience on this questionnaire, the more they benefited in terms of clinical outcomes, like increased or reduced depression symptoms and things like that. So I've seen a few studies like that are linking the mystical experience, both qualitatively through self-reports, but also through kind of quantitatively through questionnaires. So it seems to me that it may be quite important, but it's an empirical question. I think it would be quite fascinating to compare psychedelics that don't create the mystical experience and, to those that do in a clinical trial, and see what the difference is in outcomes. Yeah, we just don't really know right now. There's so much in this area that's so unknown. Yeah.
So many questions. Okay, good. Well, I also want to ask you about another research paper that you published. This was 2025 in the journal Current Oncology. Again, I'll read the title because it's pretty self-explanatory. Psychedelic-Assisted Therapies for Psychosocial Symptoms in Cancer, a Systemic Review and Meta-Analysis. Systemic review, meta-analysis, that says it all. As I recall, you looked at about 15 different studies and synthesized findings. Tell us a little bit about, you can go read the paper, but I'm curious to know your takeaways, what you took away from that meta-analysis, and what are the implications for people living with cancer?
Sure. So shout out to my master's student, Haley Schumann. That was her master's project, or part of it. And another part of it is the survey data that maybe we'll get to later. So the systematic review, it basically just summarized in a more quantitative way what we already knew. There's a few studies that are very promising, but not very much. And there's a lot of what we would call heterogeneity, or there's a lot of variability in terms of how big the effects are. Right. So we separated out psilocybin from ketamine, from LSD, and there's just a handful of studies in these areas. The ketamine studies are quite different because they're not typically embedded in a therapeutic setting with adjuvant sort of psychosocial or supportive therapy. They are often given more as a medical model, as a drug, but still the ketamine seems to have pretty quick benefit for symptoms of depression. May not be as long lasting as something like psilocybin. the effects might not be quite as big, but definitely there's promise there for short-term relief of depression symptoms. The psilocybin has been tested for depression and anxiety, but also for what we might call demoralization or the more existential types of concerns, which is the focus of CAN-PACT, is looking at more of those fear of death and dying, existential meaning and purpose in life types of questions. So that's why we're focusing in more on the psilocybin.
Interesting. Okay. And you mentioned that there is a lot of heterogeneity. There is a lot of variability across all of those studies.
And they're small, like the total number of people in these studies are like 200 or something, right?
And that's across 15 or so studies.
Across all
So
the studies. Yeah.
15 very small studies. And for people living with cancer who are looking at psychedelic medicines, and to your point, there's some promising data. What are we to make of what the science is telling us?
I think the science is telling us it's promising, but we don't know for whom, in what dose, in what setting necessarily, how often, how long lasting it might be, what the safety profiles are. I mean, so far it seems pretty safe the way it's been done in these clinical settings, but there's so much that's not known. I think if I were to sum it up, I would say it's promising.
Great one-word summary there is promising. So very good. I also want to ask about the session that you moderated this past summer, fall in Boston at Society for Integrative Oncology session on psychedelics. I'm curious what the conversation looked like, what sorts of topics came up, and what were your takeaways from the conversation?
Gosh. Well, a lot of the data that was presented was from Yvan Bossin. He's at Harvard, I think, but he's worked with your previous guest, Agarwal.
Mm-hmm.
Yeah, so he was talking a lot about the trials they've done on group psychotherapy, which is actually the model we're going to be using as well, which I think is fascinating because mindfulness is always offered in groups, and mostly the psilocybin has been individual up to now. Except for some of the work that they've done together. So Yvan was presenting even qualitative interview data from some of the participants that had been in those studies. And it was super fascinating. Yeah, he's got a number of papers that are just in press now, really understanding, and again, getting at that question of the mystical experience and how important was that to them, but also asking about the group experience. And what we're seeing, I think, there is that the group can enhance often in many ways the individual experience of feeling isolated and alone and, just sort of sharing the nature of the cancer experience just generally and kind of going on a journey together, right? It's like when you go on a harrowing, say bike trip or something, you go on an adventure with people, you kind of bond that way. And that very much, I think, happens in this journey as well.
Yeah, and it sounds like that group dynamic, that's something that you mentioned earlier in terms of the mindfulness-based stress reduction training. It's a group environment as well as the research that we're talking about here. And it's interesting to hear you reflect on why that group dynamic is so important and why it can be so healing. I'm also curious to know what the broader oncology community thinks about psychedelic. And I know that this was an
I can tell
SIO
you.
conference, and what's the perception?
Well, so what I'm going to share with you is from a survey that was also part of Haley's master's study where we surveyed over 700 people. So 500 patients, but over 150 or close to 200 healthcare providers as well. And so, a broader spectrum of, I suppose the people who answered the survey had some interest in it, it was voluntary, but really quite a broad range of perspectives from the healthcare providers, from like being quite cautious about it and concerned about safety. There was a lot of talk about not having enough evidence or not knowing what the evidence is, not understanding if it's safe for patients, and a lot of concern too about the legality of it, the regulatory environment, how do people access it? The patients were concerned about, how do I access this safely and legally? The healthcare providers were concerned about, how do I get training, or how do people within the system get appropriate training to safely deliver this? How does the system do it? How do we deliver it within the system in a way that's equitable? How do we afford it? How do we pay for it? How do we prioritize it? So really practical questions like that as well.
Mm.
We separated out policymakers from clinicians in terms of the healthcare providers. And we also asked, what are their attitudes and beliefs? Like, how positive do they feel about it? And, policymakers and the healthcare providers felt quite positively about these different
Mm.
approaches, but they saw more barriers as well, especially around safety, whereas patients saw more barriers around access.
Interesting. Interesting. And what were the perceived safety barriers? I mean, you mentioned earlier that in the research, it looks safe. And of course, we want to continue to do research on safety, but what are the perceived safety risks?
Well, so we can break it into physical or psychological safety, right? So, physical safety with psilocybin, for example, there's not a lot of risk around cardiovascular safety, but in some of the psychedelics, there is, it can elevate the heart rate or, cause some abnormalities in the heart rate and cardiac health. But that's not really so much the case with psilocybin.
Hmm.
It can cause transient headaches and nausea as well, which is pretty easily managed. So, physically, I don't think there's that much safety concerns. I think they're more concerned about the unknown stuff like the psychological safety.
Hmm.
Is this safe for people who might have a history of mental health conditions? Is this going to trigger off a psychotic episode for people? Are they going to have long lasting, potentially psychological, detrimental effects? And a lot of that is a holdover from, the war on drugs and the government propaganda around these agents and the fact that they're classified, along with things that are highly addictive. And so people are worried about addictive potential as well.
Hmm. Yeah.
And then there's a stigma, right? An interesting thing that a lot of our healthcare providers said was, well, I wouldn't tell anybody if I was going to prescribe that, because I might be judged as some kind of drug pusher. Yeah.
Interesting. And is the concern my medical credibility? Are they concerned about legal risk? What is the stigma?
It's more psychological stigma like credibility. Yeah. Yeah. I don't think people brought up a lot of legal risks. They brought up legal barriers, because access is a barrier. But not that they were worried about being hauled away by the police or anything. It was more like my community might judge me.
That's so interesting that they're
Yeah.
concerned about their reputational risk in
Totally were.
adopting.
Yeah.
Interesting. All right. Well, let's talk about CAN-PACT. You've got this lovely logo behind you there. There you go. Show off the beautiful logo. And we talked a little bit about where CAN-PACT came from, which is persistent grant writing, and
Totally.
and it has since come through. Tell us a little bit about the mission of CAN-PACT, and I really want to get to this is a 5-year program. 5 years from
At
now, what
least.
is your vision for what success looks like? What are some of those indicators of, yes, we've accomplished our mission if we've achieved these goals?
Yeah. I mean, there's 6 objectives, right? So I think we need to, move the dial on all of those. So the network is about building an entire network for practice, for research, for policy, for implementation, right? So we would need to make strides in all of those areas. So we'll be doing research to answer some of the unanswered questions. And we'll be working with policymakers to try and understand the barriers to access and decrease those barriers if we can, right? We're building a network and coming up with, so maybe I'll do it one by one. Our first objective is to build a network, which has been so much fun. We've been doing that this year. And so we did an environmental scan and we're keeping it. So our scope is about pragmatism and about implementation from the beginning. So we're including only people who work in the publicly funded provincial cancer agencies as clinicians. So the people we're training are the people who are already there. They're already staff. So we're working with psychosocial oncology and palliative care clinicians to be the providers of this therapy. So our network didn't include any private clinics or any place patients would have to go and pay. So the idea is that once we're done all the work we need to do, we're going to have the clinicians in place across Canada at the cancer centers where they get their care because we're a publicly funded medical system. So that's kind of been the ethos from the beginning, is that we want this to be accessible and we want it to be barrier free.
And I want to point out that you were thinking about access from day one and designing
Absolutely.
this to be accessible. And obviously, the healthcare model is a little bit different in Canada than it is here, but in public hospitals and public cancer centers where patients are receiving care today. So that's great. And I do want to talk a little bit about that network. Tell us a little bit about
Yeah,
how
totally.
you went about building that network. Where are the
Yeah,
big
yeah,
nodes in that network?
totally. So that was the framework, is that we were going to go across Canada and we were going to get all the researchers in the universities in the academic space who were studying this, clinicians who were in the public healthcare space, patient partners, and policymakers at the different levels of government. So we have, instead of like the FDA, we have Health Canada. But we also have provincial cancer agencies that make a lot of decisions around what treatments get funded. And we have regulatory bodies that regulate the different professions, the physicians, the psychologists, all that. And so we included all across Canada, all the people researching in this space. And our two main areas are palliative care and psychosocial oncology. So we scanned the country. Anybody who was doing research in cancer and psychedelics was immediately invited. There are not very many of them. But then there's some people doing psychedelics research in depression or, in different areas. So we invited them, and then, psychosocial experts. And so get those researchers on board. And then the relevant clinicians we got on board. We have 5 main sites across Canada that are kind of going to be, that were identified as the nodes for a multi-site trial, although we might expand because we've added a big group from Quebec as well who's been doing this work, but in French. And so bringing them in and all their previous work. And they're wonderful. They've done some fantastic work, actually, in Quebec. Michelle Dorval is leading that work, and Huzanne Farzan. It's like amazing what they've been doing. And bringing together patient partners as well, some who have had psilocybin journeys personally and some who haven't, that are just part of our networks. So bringing that all together, we've got about, 60 or so people in the network now. And we had our first, it was amazing. We had our first in-person meeting in October in Calgary, and we had, around 50 people come, and, we'd only ever seen each other on Zoom, many of us before that. So to have everybody together, we had a great time, and, we had a social event, and we had talks and networking, and it was really fantastic. The energy was so high, like people were so excited. So that's building the network. And then the thing we're launching now is called a priority setting partnership. And what this is a survey across Canada, or it's a series of surveys and a workshop, actually, but trying to get the patients and the clinicians. So just the people directly affected,
Yeah.
get their opinions on the way it's structured is evidence uncertainties, basically unanswered questions. So we're just about to launch our first survey, and it just says, what are your questions about psychedelics and cancer? And then we hone in, what are your questions about psychological effects, physical effects, safety, legality? And we're just collecting hopefully thousands of those to begin with. And they're open-ended questions. People can put in anything they want. And then there's a round of honing it down to what are the ones that are actually unanswered, because we may have evidence for many questions that people ask. So we parse them out into, okay, we already know this, we don't know this, and lumping together things that are similar into categories. And then we'll do a second round, kind of mid next year, where it's getting it down to a top 25 unanswered questions.
Yeah.
And then the third round happens in person at our next fall meeting, where we bring in a new group of people, again, patients, clinicians, to get it down to a top 10 list. And so that top 10 list of research priorities will then be the North Star, right? Not just for us, but for the entire research ecosystem. I mean, probably for many years to come, right? Because I'm sure some of the stuff on there is not going to be answered in the next 5 years, right?
Yeah, absolutely. And I love the process of starting with unknown unknowns, and let's identify what those unknowns are, and then being very intentional in terms of prioritizing those questions and designing research to back into them. And when you were talking about the network, you talked about 4 stakeholder groups, the researchers and clinicians and policymakers and patients. And I'd love to hear a little bit more about patients and how you are engaging with patients and how you are bringing them to the table so that those voices are being heard in this
Yeah,
decision-making
absolutely.
process.
Yeah, I mean, so they've been included right since the very beginning. Like even the very first grant application had one patient partner on it, and she's been amazing. Hillary, her name is, and has had input at every stage of the way, and often will be saying, well, I wouldn't want to do that, or I wouldn't want to fill out that questionnaire, or, that's a little much. And so we've added in a number of other patient partners as we've expanded. So one wonderful woman, Deanne, actually shared at our network meeting she's had 2 psilocybin journeys. And so she shared her story at the network meeting, and it was amazing. And actually it's recorded. I think part of it might go out on our YouTube channel pretty soon. but really inspiring to share her experience. And then we also have some patient partners that I've been engaging with for many years just through integrative oncology, some of whom have never tried psychedelics or aren't even that interested, so just try and get a broad range of perspectives. So we have them on our steering committee. We have them on all our subcommittees, like, for example, our education, our public education subsample of our education is led by one of our patient partners, right? So yeah, and everything we do, like right now, we're just test driving the priority setting questions with a group of patients, and we'll be test driving all the different questionnaires we might use in our clinical trials. So we engage with them throughout.
I'd love to hear a little bit about why those patient perspectives, why those patient voices are so important. I mean, conceivably, just to play devil's advocate, you could have excluded patients from this process, and it could have been clinicians and policymakers and
Yeah, like research often
researchers.
is, right?
It often
Yeah.
is. And tell us about why those patient voices are so important and how they impact the process.
Well, like nothing about us without us, right? I think is a really important mantra. It's like, who are we to tell people what we think is important to them, right? I know what's important to me as a researcher or as a clinician, but that doesn't really matter, right? Because we're there to provide the best possible care we can for the people that we're serving, and who better knows what their needs are than them. I mean, it's very paternalistic to presume that we know just because, we're the doctor.
Nothing about us without us is just that's a great mantra. It's a great motto. And I guess I love the humility of we do need patient voices. I know myself, having been a cancer patient, it can sometimes be paternalistic in a relationship with a physician who says, this is what you're going to do. This is the treatment protocol that you're going to follow. And it's scary being in the health system. And so the fact that you've elevated those voices from the get-go, we're going to embrace that motto of nothing about us without us. I just love it.
Yeah. And I mean, who, especially in the area of psychosocial care and, people's internal experience, like I can't put you on a scale and measure your pain, right? Like there's no way to get at it except by talking to people about their experience.
Yeah. Yeah. Well, I want to talk about that second objective. You touched on it a little bit just in terms of setting priorities, and you talked about the process that you're going through of identifying questions and prioritizing those questions, and then designing research around it. I'd love to hear a little bit about your perspectives, knowing that this is still somewhat in process of identifying what the research priorities are and designing what protocols will look like
Yeah.
to address them.
Yeah.
I'd love to just start with the patient population and how you define inclusion criteria into a trial. Who do you expect to focus on, or who do you anticipate to focus on?
Yeah. Well, so we are in the middle of designing our first pilot study that's going
Yeah.
to be testing a lot of these things, but we have chosen to focus on people with advanced cancer, meaning stage 3 or 4, so not terminal, quote unquote, or not palliative care, but people who are dealing with diseases that are largely non-curative. So more advanced disease, because the outcome we're mostly interested in, as I said before, are those existential concerns, the demoralization syndrome, which is potentially more prevalent in people who are facing, more imminent end of life. That's not to say that these kind of therapies couldn't be good for everybody. And maybe right after diagnosis, everyone should get their psilocybin, right? And that might be a really good way to start. But for us, we're starting with that more advanced disease population and focusing on those existential outcomes. Although we're measuring all kinds of stuff, we're actually just trying to narrow down all the different things we want to ask people about, because there's so many, right? We got to ask about their mystical experience and, their spirituality and their connection with something larger and how it affects their relationships and all their symptoms. And I mean, there's so many things that are of interest, right?
Yeah. And I think it makes sense to focus on more advanced cancer, stage 3 or 4. I'm also curious if there will be any requirements or inclusion criteria in terms of psychosocial symptoms and how you define those
Sure.
psychosocial requirements.
Yeah. So there's no point in focusing on improving something that someone doesn't have, right? So you wouldn't treat someone for depression if they weren't depressed. So if our primary outcome is demoralization, we want to include people who are demoralized. And so there's a screening tool you can use. You just ask them a few questions and, you can identify the people who are struggling the most, and that's who we would focus on. But around other inclusion, exclusion, our approach is to be as pragmatic as possible, as real world as we possibly can, right? So again, I said we're doing it in the treatment centers with the staff who give the care, and we want to do it as much as we can to the people who receive the care. So trying to balance safety, because, with a lot of the earlier trials, the exclusion criteria are so many and the inclusion is so narrow that so many people wouldn't even be eligible. So we're trying to broaden that as much as we safely can around, for example, previous trials might have had people taper off of antidepressant medication like SSRIs before they could go in the trial. We're not going to do that. We're going to let people stay on their medications. We're just hashing out all the cancer drugs and, which might have interactions, and got a whole subcommittee working on that. But the general principle is to be as broad as we possibly can.
And you've also mentioned demoralization syndrome, which I when you say it, I know as a cancer patient, I know exactly what you mean, because it's not depression, it's not anxiety, it's not existential distress. It is demoralization syndrome. And also, diagnostically, I'm not sure exactly how you're defining demoralization syndrome. What is that?
Well, so there's a scale and a concept around it, and it's got a number of different components, but it's like feeling helpless, losing that sense of motivation, or like basically just feeling like you want to give up, feeling exhausted and feeling like why bother, was no sense of purpose in life. So you're right, it's distinct from depression, although somewhat overlapping. But it's really hard to treat. Right. And it causes a lot of distress for the healthcare providers, for the family members who just see somebody being so down and like kind of giving up. Right. And losing hope too. Like hope is so important. That may seem paradoxical, hope at end of life, but to me, it's not at all. Right. It's a matter of what you're hoping for.
Yeah, I just love the term because it perfectly captures what it feels like to be a cancer patient, to have that diagnosis, to have that prognosis. And also, it's more accurate than depression or anxiety or whatever that is. I guess my question is demoralization a recognized DSM indication? Is it something that if this
No,
was
no.
approved, you can prescribe
Yeah.
a medication for?
Yeah, the whole system is broken around how things like drugs or psychotherapy. I mean, psychotherapy is not approved. So I come from a psychotherapy background where nothing's approved or doesn't need to be approved to be used. But now we're combining it with this drug model, which is not a good fit, right? So in the DSM, it could be under adjustment disorder, not otherwise specified. So there is a code you could fit it under. In the ICD-9, which is used in Europe and other parts of the world, there actually is one now. There is a code for demoralization.
Really interesting.
Yeah. Yeah. And
Interesting.
you know what? I have to confirm that, but someone told me that. I haven't looked it up, but I read that somewhere recently is that the ICD, whatever they're at, 10, 11, has got a code for demoralization. Yeah.
Interesting. Well, and all of this eventually matters for access and
Yeah,
insurance
absolutely.
coverage, and so it's I love the concept, and I think it's just ingraining it into
Well, the
treatment
interesting
patterns.
thing, yeah, is that like the only way that people access these compounds now in Canada is through something called the Special Access Program. But the criteria for the Special Access Program are basically demoralization. Like it's not you have to have a diagnosis from the DSM.
Hmm.
It's you just have to feel demoralized and make your case, and then we'll let you have access. Right. So it's a bit odd that way. I don't know. So maybe they'll carry it through, right, when they give approval.
No, and I hope so. It was interesting. I was having a conversation with someone about the special access program and just how difficult it is to get approval under special access as compared to medical assistance in dying. And the
Yeah.
point she was making is that it's easier to die than it is to heal in Canada. And boy, that's really sad. And to the extent that we can widen the access lanes in these definitions so that people can start to heal, it's just really, really, really important.
Yeah, people bring up that paradox quite a bit, like in our interviews and things, about I can prescribe medical assistance in dying, but I can't prescribe psilocybin that might help heal some of those same reasons that make people compelled to want to shorten their life.
Yeah, yeah. Okay, good. Well, I also want to talk about research priorities just around the protocol. So it sounds like you're probably going to focus in on psilocybin just based on your previous comments. And then I'm curious to know what the treatment protocol looks like. You mentioned
Mhm.
earlier some of the benefits around group therapy. My guess is all of this is somewhat in flux, but if Linda got to decide what the treatment protocol would look like, what are your
And
thoughts?
like unveil it. So we are planning to do group based and we are planning to do hybrid, so partly online and partly in person. And we are planning to try and separate out the effects of the psilocybin from the effects of the mindfulness and the combined effects of both.
Thoughts on how you're going to do that? I'm just trying to process in my
Yeah, and
brain
we have a
how you parse
design.
that out.
Yeah, no. Well, I guess I can't really say too much about the design because it's not quite finalized, but there are ways to do that methodologically that we're looking at. That's, yeah, really quite fun if you're a methodologist, is trying to figure it, well, fun and exasperating because you've solved one problem and you cause another problem, right? Yeah, but in terms of methodology, actually, we just had a meeting today of our clinical trial subcommittee with about, I don't know, 15 people hashing it out, right? We're like duking it out. No, we should do this. I gotta do that. No, what about this? What about that? Yeah. So it's quite not quite finalized yet, but we know the big pieces. And this is just for our pilot work. And that's gonna happen at 2 sites starting next year, once we get it all finalized and approved. And the pilot trial is gonna help us optimize the treatment that we're gonna offer in our multi-site trial. So optimize it in terms of efficiency and effectiveness.
And just to clarify what I think I heard too is that there's going to be psychedelic therapy and mindfulness based therapy combined. And then methodologically, you'll be able to separate out the impact of which therapy on outcomes.
Yeah, so we'll have conditions where people might only get mindfulness, somewhere they'll get both, somewhere they might only get psilocybin.
All right. Well, I would love to be in the room where those conversations are happening, but that's maybe for another day. I'm also just curious about anticipated outcomes that you'll be studying. You've mentioned some of them earlier, but what are the outcomes that you're most interested in?
Well, at this phase, I'm interested in really understanding the role of the psychotherapy along with the psilocybin. Again, as I said, both individually and together, because there's been so little attention paid to that, even though everyone acknowledges how important it is to have the right setting and the safe container and to process and integrate everything. But the way that that's happening is very inconsistent in the trials that are happening now. So I'm really quite interested in standardizing and evaluating the wraparound care, the psychotherapy part around the drug administration. And we also have a lot of people on our team quite interested in dosing.
Hmm.
So do we need a megadose like a 25 milligram? What about microdosing? What about these MIDI doses?
Hmm.
And really trying to understand the dose response and the mystical experience and how important that is. So teasing apart some of these questions, we'll probably be trying to do that in this series of trials.
Good. And you're going through a rigorous process to identify those questions. You talked about that earlier of identifying those unknowns. For you, what are
Yeah, I
your
mean, in that, I'm just going to say, so we've got the pilot trial that we're designing that's kind of going parallel to the priority setting. But once we get all the results of the priority, that's why I have no idea what our multi-site trial is going to look like. Quite honestly, it could go a million different directions, and the field is progressing too. So it's going to be a couple of years till we get there, and who knows what the most pressing questions are going to be then, and what our priority setting partnership, top 10 is going to tell us people really care about. So that's the fun thing about it too, is that, this grant allows us to, I often say we're building the plane as it's taking off, right? And really be adaptive or adaptable. And I think that's
And that's so good that you're building that adaptability from the outset, just given how rapidly things are changing and you can be flexible in evolving with the landscape. Within those questions, what are your biggest questions? Where are your biggest unknowns that you would like to prioritize?
well, I guess they're on opposite ends of the spectrum, right? There's the really practical stuff. Like, how can we really make this something that is possible to integrate into cancer care broadly across the country? And those are very pragmatic, practical kind of things. How much is it going to cost? How are we going to train people? All those kind of things. How are we going to get the all the policymakers on board and, what's the process there, right? So a lot of process-oriented practical things. But I think at a more higher level abstract sort of level, I'm just super fascinated by what's going on when people are doing these practices. And, again, we talked about the mystical experience and how is it that somehow jumpstarts this process of self-transcendence and non-dual awareness and, that we see and have experienced, some of us, in meditation practice. Like, how does it happen with the psychedelics? Like, what's going on? It's just so fascinating. Yeah.
Yeah. No, I mean, it's absolutely right. Is we have this mystical experience and it leads to some of these outcomes, but the connection as to why that mystical experience leads to some of those outcomes, like a non-dual perspective. Do you have any hypotheses there, just in terms of what's going on neurologically or physiologically?
Well, I think a lot of what's going on relates to consciousness, which may or may not reside in the brain, right? So there's lots of people doing EEGs and fMRIs and PET scans and trying to see what happens in the brain. I'm actually not as interested in that. I'm more interested in beyond the self and self-transcendence and connection with something you might call consciousness, which I actually think is not body-based, right? So, I mean, there's, lots of interesting questions around that and in getting into issues of the biofield and, energetic concepts. And I find all that really fascinating. And just because we don't necessarily have ways to measure these things with our brain scanners doesn't mean they're not equally real as the things we can measure. The Western biomedical model is so limited, so limited. Yeah.
And so much of what you're talking about is transcendence, is understanding consciousness outside of self and transcendence into that bigger thing that you can
Yeah, and that seems to be
experience.
what's key, right? You
Yeah.
just need to transcend the self. However, you can do that, and you're not going to suffer as much, And it takes maybe right back to the first noble truth. Well, first noble truth is the existence of suffering. The second noble truth is the cause of the suffering, which is grasping and identifying with the smaller self, but grasping on, things being and pushing away, right? So the unwillingness to acknowledge and accept constant change, right? And the ability to sort of let go and go with the flow and yeah, all that stuff, right? And identifying with the ego. And so how the psychedelics fit into that framework, and similar to how the meditation or these other forms of mindfulness fit in. It's just fascinating to me.
It is fascinating. And it's so interesting that whenever we have these conversations, they start in a very hard science, research-based conversation, and then they start to get out into the edges or the frontiers, into things that we've intuitively experienced or we subjectively kind of know, like transcendence, but they're really hard to measure. And there's always just this tension between science and
Yeah.
subjective experience.
Well, when all you
And
have is a hammer, everything looks like a nail, right?
yeah,
And so we start there because those are the methodologies we're familiar with and we're kind of allowed to use more or less. But that again takes us to the edges, right? And where do we go from there? I guess we'll see.
we will see. And I look forward to watching you and seeing with you and learning with you. So, Linda, this has been great. Just to wrap us up, would love to hear 2 guests that you would like to see on a future Healing Cancer Journeys podcast.
Yeah, I think it would be great for you to talk to one of our patient partners, like Deanne Grattan, who spoke at our network meeting, tells her story just beautifully. I'm sure you've probably done that, talked to a number of people who've had their own journeys, but she's wonderful. And gosh, there's so many amazing people in our network. Like Ron Shore has just done he's the same age as me, but had recently completed a PhD in psilocybin and has a rich, experience of 20 years as being a guide, for psilocybin journeys and working in harm reduction. And he has such a broad grasp of the historical story around different psychedelics. So talking to Ron would be a fascinating conversation, I think, for you. And then there's Erica Dick in Saskatchewan, who's a historian of psychedelics. I don't know if you've ever heard of her. Yeah, so she has the transcripts from the people who worked with Henry Osmond, who was in Saskatchewan, right? Who did some of the very first psychedelic trips with LSD and stuff with patients. And so she's a historian of psychedelics. and works also with First Nations, Indigenous communities, and Native American church in their peyote ceremonies and things like that. So she's super interesting as well.
Great. Last question, Linda. If people want to find you or CAN-PACT online or in social media, how do they find you?
CAN-PACT. Yeah, start there. Actually, is it CAN-PACT? Is there a hyphen? No, it's just CAN-PACT. I got to double check. I'm on it right now. Yeah, www.CANPACT, so CANPACT.ca. And you can find everything you need there. Yeah, and we're on socials. We have a great comms person who's really, we've got a YouTube channel, LinkedIn, and Instagram and Facebook as well, our main channels.
Well, Linda, thank you so much. Thoroughly enjoyed this conversation, and it's certainly informative for our community. So thank you so much.
Yeah, it's been great talking to you, Dan, and congratulations, for providing this podcast. It's I think, a really important service for people. Yeah, and the best of luck with your own journey as well.
Yeah, thank you. I appreciate that.